All right, I'm just going to start letting people in.
Good morning, everyone. Hey, Stephen, Andrea, yay. Lisa, I see you. Great.
Audio check.
We can hear you. Terrific.
And you guys are running the slides, right? We're not popping back and forth. Wonderful.
Timmy,
Thank
you
you,
can see me?
everyone. Yep, Lisa, audio.
Great.
Great.
We already have a lot of good people on this call. It's great.
Yeah. Such
Very
a
exciting.
powerhouse group we get to see every other week. Andrea, I see you're here. Great. We'll just give a couple more seconds here for folks to come in. I don't want them to miss the discussion. Welcome to Connecting for Better Health, everyone. A lot of familiar faces here. So glad to have you join us with the conversation. New faces as well. As we always start our conversation, please use the chat to introduce yourselves. Some of the best part of this coalition is all of our networking we do outside of our meetings. So please introduce yourself. All right, we have a fantastic agenda that we've organized for you. Really hats off to the team that is part of the conversation today, and also to the Connecting for Better Health team, Olivia, Stephanie, Maya, that have been working behind the scenes to be able to ensure we have a quality discussion. Thank you so much. So we are going to dedicate most of our meeting today to discussing AB 352 that is impacting, I think, a lot of our mind space as well as our implementation teams of thinking about how we're going to help implement AB 352, which you all will learn the intricacies of it, both
Timmy, you went on mute.
Have I been on mute this whole time?
No, just the last 15 seconds.
Okay, I didn't do that, but welcome everyone again. So we will be kicking off this workshop that will be focused on AB 352, which is helping to protect reproductive health in the state of California. We never stray from the tough topics. Last year, we tackled consent in a 4-part series, as well as wrote our paper with the California Healthcare Foundation. And we keep hearing about the concerns as well as work that's going on in the field about AB 352. And we thought that it would be a great way to be able to bring you all together. So we have some time of setting a stage. Lisa Matsubara from Lisa, from Planned Parenthood will be here to walk us through the intent of the bill. Andrea Fry, our trusted advisor at Hooper Lundy and Bookman, will walk us through the legal considerations. And then we've also invited Dr. Stephen Lane from Health Gorilla and Dr. Raymond Yu from the National Association of Community Health Centers that have been working diligently around thinking about the code sets that are stored in our electronic health records and other systems that we should all be well aware of. Then we will have about 20 minutes dedicated to group discussion. We have some facilitation questions and a discussion guide that we sent out to all of you. I think that that'll be in the link as well that you can follow along. And then we'll wrap up and summarize some next steps. And hopefully we are going to think about and pull together some action steps for all of us to either take back to our own organizations, for us to escalate to other organizations, including the state. And, you know, really just to keep the conversation going. And then I'll have just a few minutes of an update with what we're doing with the DXF Sandbox that I want to share with all of you, and also our design studio that we're just getting kicked off. And as always, we have our other updates for you, and it's in the deck. Hopefully we'll get to it. So I'm going to hand it over to Lisa, who will, I guess, provide the orientation to us of AB 352. Lisa.
Hi, everyone. Thanks, Timmy. Thanks for having me. Just a little bit about my organization. I'm the Chief Legal and Advocacy Officer at Planned Parenthood Affiliates of California. Some of you on the call probably have seen me around for a while. I have been in sort of the HIT space for a long time. I previously worked at the California Medical Association with a focus on this area for over a decade there as well. So you may have seen me in my previous capacity. My organization is a statewide public policy org that represents the 7 affiliates throughout the state of California. The affiliates provide a lot of healthcare to folks. We actually provide a third of the care to all Planned Parenthood patients across the country. And they have over 100 health centers plus school-based centers throughout the state. Next slide, please. So I did want to come in to just give a little bit of context. PPAC was the sponsor for AB 352. We did actually, prior to introducing this legislation, talk to a bunch of folks and solicit input on this. Just the reason why we actually brought it up was that, as you can see this map from Guttmacher, since Dobbs, the decision in Dobbs that overturned Roe versus Wade, we have seen 21, it will be 22 if you include Arizona, who's not really sure what the repeal is going to happen with the absolute ban that is scheduled to go into effect in June, but that will be 22, have states that either ban or severely restrict abortion in those states. And many of those states actually have criminal penalties associated with their bans. What we started seeing is that folks who were traveling from those states to get care in states like California were discovering that when they went back to their home state, that their providers in their home states could see that they had traveled to places like California to get abortion care. And that was through health information exchange, other tools in the EHRs that were sharing information. Obviously, as everyone on this call knows, we have been working really hard to make sure that there are fewer barriers to health information exchange for a long time, but also the environment has changed dramatically. The other thing that I do want to know is that some of that data, this data is actually pre-Dobbs, but we had been seeing folks getting criminalized for pregnancy loss throughout the country. When, how, which represents a lot of these people, sort of runs reports on the data. Many of the folks who get reported to law enforcement was through their healthcare provider. We started getting really concerned about some of the very stringent criminal penalties that were associated with some of these abortion bans going into other states. We're also concerned about the fact that different states have different minor consent laws with regards to privacy, and that the free flow of information from access states into these banned states were actually creating a security risk to the patients as well as the providers in those states. We actually worked with some vendors ahead of introducing the legislation to try to see if we can find a solution. Many of the solutions that were offered were either individual basis, so like contract by contract with the vendors and individual providers. And we didn't really feel like that was a good solution to really protect the information, particularly in light of what was happening with just the general movement for more health information exchange, the state's push towards data exchange framework, and the federal information blocking rule. We also legally felt that the federal information blocking rule, we really wanted a very clear exemption from that with regards to privacy. So if providers did feel like they did not want to have abortion data be flowing across state lines, that they would not be in violation of the federal information blocking rule. So that's kind of where we are. Just that one box in the corner to abortion is extremely common healthcare procedure. And that statistic that 1 in 4 women or people of reproductive capability do have an abortion by age 45. So it's a very common procedure. Next slide, please. So one of the things that we did here in terms of as we were trying to implement this kind of at the vendor level was that one way to get sort of consistency across the line was if there was a state law that actually mandated that some of this information needed to be protected. We also felt there was a need because of the information blocking rule. And so this was AB 352. It essentially has 3 components. One is that businesses that store and maintain medical information has to develop the technical capabilities to be able to segregate some of this medical information related to gender affirming care, contraception, and abortion. The compliance deadline for that is July 1st. I will note that healthcare providers under the CMIA are exempt from this provision. It does not apply to them. The second section, it does apply to providers that requires that providers cannot knowingly share information related to abortion and abortion-related services outside of California without authorization. This is modeled after Part 2, or the previous Part 2 before the new rule came out. And that went into effect January 1st, 2024. This is the piece that I was talking about with regards to a state law that has more confidentiality protections to really trigger that privacy exception and the information blocking rule. There is a implementation and enforcement delay on this provision. And folks do have till January 31st of 2026 to try to get into compliance. And then finally, on the data exchange framework, we did want to make sure that within the state data exchange framework that there was provisions that explicitly said that you do not have to share information, health information related to abortion as part of the data exchange framework. So those are sort of the 3 main components. I will just, as a caveat, I understand that this is very complicated to implement. And that it was, we were not under the impression that this was something that was going to be easy. We're definitely happy to be working with you all to find a solution. I think at this point for us, we really felt that there was a real need to make sure that we are protecting this information in states like California. So that when folks do have to travel from out of state, and they are traveling from out of state to get care here in California, that when they go back to their home state, that their medical records are not the thing that ends up being the evidence to criminalize their actions when they were getting care here. So that's kind of my summary. And I think, Timmy, we're doing questions later, right? So maybe I'll kick it to Andrea.
Yeah, sounds good. Thank you, Lisa. I do have questions for you, but I can save those for later too. But I guess let me just, while I have you, so as far as, enforcement of this, and also kind of guidance coming out from regulatory agencies, really the only thing I've kind of seen so far is the AFL from CDPH at the beginning of the year. Are you aware of kind of any other, guidance or leadership from state agencies and kind of leading the charge on AB 352 implementation?
Not really. I know the data exchange framework subcommittees, and just a caveat, I do sit on one of the subcommittees. They have amended some of their policies and procedures to include a reference to the fact that that sort of third box that I was talking about, to make sure that that information, it's clear that folks do not have to share that information. But aside from that, I haven't seen too much in terms of guidance or enforcement on this. I think, our sort of desire for this is that we do want to make sure that there is there's some flexibility for folks as we try to figure out how to sort of solve for this issue that we're trying to make sure that people are safe. But Haven't seen anything like definitive in terms of guidance from any state agencies on this yet, other than DXF.
Okay, great. Thank you for that. Yeah, and oh, Trina, I see you have a question. I don't know, Timmy, do you want to save questions for later or?
Yeah, happy to wait.
Yeah,
Similar.
let's go through. And so we have everything like level set, and then we'll address some questions, and then we'll go into our facilitated questions.
Okay, great.
Thanks, Trina.
And just for introduction, my name is Andrea Fry. I'm a partner at the law firm of Hooper, Lundy and Bookman. I focus exclusively on representation of healthcare providers, digital health companies, health information exchanges, and the like. And I am the co-chair of our digital health practice and our reproductive health practice that we formed shortly after the Dobbs decision came out from the Supreme Court. Next slide. So just kind of actually before we get into the HIPAA reproductive health final rule that was released earlier this week, I kind of wanted, Lisa really did a great job providing the technical legal requirements to AB 352. So just sort of, I wanted to kind of offer some kind of compliance considerations for, both healthcare providers and other types of organizations like HIEs, EHR vendors, now on the ground, kind of figuring out how to implement this. And I think it comes at a time where, these types of organizations are kind of caught in between, on the one hand, information blocking rule, interoperability requirements, data exchange framework, and really the sort of push for a broader information sharing ecosystem, as Lisa pointed out. And then on the other hand, we really want to ensure that this very sensitive information from patients, isn't shared in such a way that either discourages patients from seeking needed care or, from providers ultimately providing that very crucial care and the like. So, I think AB 352 does, really try and it does create some, technical and compliance considerations though for these entities. For example, how do you actually kind of segment or identify and tag the reproductive health data, that's subject to AB 352? Is that through a manual process? Is that ultimately through, an algorithm created by, via artificial intelligence? And so I think there are going to be some kind of questions, and considerations going forward in that regard too. And so, I do think, I know this is going to be a subject for discussion with Dr. Lane later, but it's something that, all these healthcare providers, HIEs and EHR vendors are going to need to develop, robust policies that really specify kind of the circumstances in which this type of information may or may not be disclosed and how to do so appropriately. So now turning to the HIPAA reproductive health final rule that came out, I only have a minute left here, but just kind of very briefly at a high level, the final rule, I think kind of the main change is creating this new category of purpose-based prohibition on uses and disclosures of PHI for the purpose of conducting criminal, civil, or administrative investigations or imposing liability on individuals who either seek, obtain, or provide or facilitate reproductive health care where it's lawfully provided in that state. So for example, the context of the rule is pretty narrow in the sense, OCR could have done kind of as it did with psychotherapy notes, for example, and creating this kind of separate category of protected health information. Instead, it really took this purpose-based prohibition to kind of narrowly, avoid implicating any sort of state autonomy issues and the like. And then along with that, other changes to, for example, definitions in the privacy rule with regard to who a person is, clarifying it's not, a fetus, for example, and then also requiring a very specific attestation from the requester, who intends to seek the PHI that potentially is related to reproductive health care, just validating that it is for an authorized use. I'm happy to talk more about that offline or in the question and answer.
Thank you so much. So I think we'll go ahead and move then. Hold your questions. We'll move to Stephen and Raymond.
Wonderful. Thank you. Hope you can hear me well. Thank you so much for the opportunity to contribute today. I've been Chief Medical Officer at Health Gorilla for about 1.5 years, but have been working in the interoperability and privacy space in California for decades. So know many of you from the past, and very excited to be presenting a piece of the toolkit that is going to be needed to support compliance with both the California law and eventually, I think, with the new OCR rule. I'm joined by Dr. Raymond Yu, who's another physician informaticist who's working at NAC. And on the next slide, you got a little bit more of the particulars about us. Our focus today is really on again, just this piece, which is how do you identify the discrete data that represents the highly sensitive conditions that are now being regulated, be they the conditions named in the California rule or now in the new federal rule. So we're going to talk you through how we got there and then offer these resources to the community. Next slide. So as we thought through how to approach this, the first task, of course, is to define the data that we're talking about. Again, we're talking about only discrete data for the most part at this point, as opposed to the data that's locked in free text notes or scanned documents, et cetera. But this is, a crawl, walk, run sort of problem that we're facing. Once we define what data we're talking about, how to find that, how to then analyze and report on the presence of that data, and then we want to be able to tag that data specifically and then enforce restrictions. So this work is being coordinated with other nationwide efforts that are going on. I co-chair the Sequoia Project Privacy and Consent Work Group with Devin McGraw. We're looking at gaps in this domain, as well as the best methods to use for data segmentation and consent management and implementation support for that. We're also working with the SHIFT interoperability work group, which eventually would like to also specify at a national level what are the value sets that should be used for compliance, and then who will be stewarding that. Next slide. So this work has been supported by a broad collaboration. We started working with AHIMA. They were interested in preparing their partners and members for compliance with the OCR rule. So they invested a lot in this early on. And then we connected with Raymond and the team at NAC, who have already been doing a lot of work in value set development and stewardship. And they are committed to developing, making publicly available, and maintaining the value sets that we will all need to support the management of this highly sensitive data, including value sets as needed for state and regulation-specific groupers. These were all developed using the Clinical Architecture's Scimedical data management platform, and they have been posted now, as of a couple days ago, to the National Library of Medicine Value Set Authority Center, and we'll give you some details about how to get those and how to use them. And the idea is that for now, for the foreseeable future, NAC is committed to continuing to develop and maintain these value sets as the regulations continue to advance. Next slide. So we really looked extensively at the definitions that were needed, when we're looking at reproductive health services, abortion-related services, obviously called out along with contraception in AB 352. There are other highly sensitive data categories in the OCR rule, including, pregnancy, prenatal care, infertility, et cetera. So we need a lot of different value sets. California's AB 352 is the only one that names gender affirming care, so that there are specific value sets that have been developed around that. And the idea is that organizations that are implementing a compliance program can pick and choose which value sets they need to utilize to meet the requirements of the statutes that apply to them. But within these value sets, we've got diagnoses, medications, procedures, as well as some documentation items. These are the things that can be supported in the VSAC on the National Library of Medicine. So that's what you'll see in the value sets. Next slide. So for gender affirming care, you can see that this is made up of a number of distinct value sets that are used in combination and grouped together to identify and define that related data. On the next slide, you can see similarly the value sets that apply to abortion and abortion-related services. On the next slide, you will see contraception. So quite a number of distinct value sets which can be combined as needed to support your requirements with regard to compliance. We've got a note at the bottom that, we did the best we could to anticipate what was going to be included in the OCR final rule based on the NPRM and have most of that content covered by additional value sets that we're not going to enumerate here. But now that the rule is out, we've done some analysis and it looks like there are some additional value sets that are going to need to be developed. And Raymond can talk about the timeline to get those up and posted. Next slide. So just a little bit of a sample here. So Health Gorilla maintains a data platform that's been in use for a number of years, exchanging on the national frameworks and networks. Within that platform, there are 28 million total patients. Within California, we've got 2.7 million. And when we use the value sets that align with the codes relevant to AB 352, 1% of all of the individuals in the data set did have data that matched the value set. Clearly well below the 1 in 4 women who will have an abortion in their lifetime. So this, again, this speaks to, what can we do with discrete codified data in our systems? Next slide. So I'm going to turn it over to Raymond, Dr. Yu, who will talk us through how to access the value sets and put them to use in your system.
Yes, thank you so much, Dr. Lane, and thank you everyone for joining. For those who are just encountering for the first time what the value set is, I urge everyone who is working with data, terminology, standards, ICD-10, SNOMED-CT, LOINC, RX norm, NDC codes, you name it, please go to the Value Set Authority Center website. There's a QR code right there, or just Google it and you'll be able to see it. Again, this is hosted by the National Library of Medicine. If you go on to the next slide, you will see that you will need what's called the UMLS license. UMLS stands for the Unified Medical Language System. The UMLS license will allow you licensure to use and utilize and look at the codes. For example, ICD-10 CM in the United States, SNOMED-CT, RX norm for medications, LOINC for laboratories, for example. The licenses for those terminologies are hosted by the National Library of Medicine, and through UMLS license, individual license, you'll be able to use it and harness it. It takes around 1 day or 24 hours from requesting a license to getting a license, and it will allow you to log in and use the Value Set Authority Center. Among the other tooling that you will see there, one of note would be what's called the NLM's Meta Thesaurus, which will allow you to put concepts there and look at which codes and different terminology standards apply to those. So please visit VSAC, and through there you will get access to the application programming interface. If you are working with your informaticist or your data analyst, you can pull the value sets directly through the API or export them manually in the VSAC website. On the next slide, you will see kind of a preview of what this looks like. And I urge you guys, if once you guys get logged in and you want to see all of the value sets that we have published, including those related to CA AB 352, please go to the filter and filter the steward via NAC, that's NACHC. You will see a screenshot over here on the first thing that you will see. Please note that there are groupers, which means there are value sets or groups that group things together. An example of this would be contraceptives all, which is a value set of all RX norm codes, basically all of the available contraceptives in the market in the United States to date. And we, like what Dr. Lane said, we are committed to update these as the terminologies update. These are intentional steps. Some of them are automated, meaning if there's a new drug that comes out, it will automatically get added to the value set. So just a note there. For the developers doing it through the API, you can use the API to use the OID or the object identifier to get all the codes into your system so that you can build your queries. Next slide. Just a few more over here. This is a screenshot of the abortion value sets, among other things. There's almost 200 value sets. And Dr. Lane did mention earlier that we are committed to add a little more to address some of the wording in the OCR final rule. So please check these out. Okay, on the next slide, you will see that each value set has 4 things: clinical focus, inclusion and exclusion criteria, and the data element scope. The example here would be what you're seeing now is the value set for abortion, elective. We are very strict with the semantics here because you can because the elective means a lot of things, and we made sure that the abortion is not taken by itself, that we tease them out and has subcategories that make sure that you can look at your data and you can protect that data as well. You're seeing it right here that there are exclusion criteria, meaning those that are not elective is completely excluded. Unfortunately, there are only 2 codes here, but those are the only ones that are semantically related to, again, elective abortions. Next slide. I think we're almost done. Again, this is what you will see on VSAC. Again, they have a fire terminology service if you're doing firework. Again, this is a lot of people are using this, so I urge again everyone, please get the UMLS license and check out those value sets. We are open to feedback. So if you see any codes that are wrong or codes that you think should be included, please let me know ASAP, and I will get that reviewed and updated for everyone. Thank you so much.
Thank you, Raymond. And on the next slide, we are planning on doing another webinar on this material, digging deeper into this on Tuesday, 5/14. You're welcome to register for that. We are going to give an update on the progress towards delivery of the value sets to support the new OCR rule and the timing of that. They might even be done by then, but we shall see. We're going to also, that's going to be nationwide in scope for that webinar. So we're going to have representatives from Maryland and talk about the value set associated with their privacy rule, and then also dig deeper with a representative from clinical architecture into just how these value sets were developed. Ray started to talk about that, but there's a lot of detail there, and how they can be implemented in your health IT system, in your organization, to support your compliance efforts. So this was just meant to be a teaser, and we hope to see you again in a couple of weeks to talk further.
Well, we have some questions coming into the chat. I just want to also offer my thanks for the leadership. I think all of us collective, the leadership, Dr. Lane, Dr. Yu, Lisa, Andrea, that you all are helping leading the way here. And I mean, it's an incredible amount of work. And I think I heard Dr. Yu, you said if you have some any changes that you're volunteering to be the one to be able to make those changes. So again, thank you. I am just going to open the floor to our presenters. Do any of you have any questions to each other?
I mean, I just wanted to respond a tiny bit to the question that came up in the chat about the unstructured data. I think that there's going to be a whole other set of challenges related to that, related to natural language processing, potentially leveraging AI. You know, this is not specific to reproductive health or sensitive data. I mean, the idea of pulling discrete data out of unstructured data and being able to act on that is critical and necessary across the health IT spectrum. So yes, I mean, we're going to be working on that at Health Gorilla, but there's not an easy answer. Again, this is a crawl, walk, run. We're starting with coded value sets to look at protecting the coded data, but we know that that's not everything that's needed.
Yes, and I want to respond to that as well. And Dr. Lane's response was really on point. It is in the onus of the organization that are hosting and recording this information in clinical notes. So, I mean, those get transferred through CCDA or CDA architecture in a SOAP note or whatever. The idea here is you need to protect the unstructured information immediately. You have to audit and do some searching in your database and how these things are getting recorded by your reproductive health providers. If it's on a note somewhere, there should be a way for you to limit access to those by filtering by provider, for example, by note type. So again, we're starting with, again, structured information, but for unstructured stuff, there are definitely ways, but you need to explore what you have. That's the first point that you should do. Thanks.
Thank you, Rita. And there's another question that came in as well, which is if we're taking these steps to limit the data as women who return to their home, what happens if there's complications and the PCP is unaware of what happened, or is not able to get that information? It's a practical question.
Yeah, so we actually got a lot of those questions when we were running this legislation. Our folks, our experts did come and testify. We actually also had an OBGYN who was part of our health committee. Our understanding is that there are very few complications where first of all, the patient can always authorize, right, to access that information. But aside from that, for many of these complications, there is actually no need for the emergency room physician to know whether or not there was an abortion or not. The treatment for spontaneous abortion or miscarriage would be the same as if it was for something that was not a spontaneous abortion. And so our understanding is that from a clinical standpoint, that there is no need for that information. And we did weigh sort of the need for that information clinically versus like sort of the danger it poses based on the legal structures in those states.
Thank you, Lisa. And Trina, did you still have your question?
Oh.
There you are.
Yes, thanks, Timmy. It's kind of a follow-up to Andrea's earlier question to Lisa. And I think, I know I'm getting a lot of questions. Again, Trina Gonzalez, sorry, from the California Hospital Association. I'm getting a lot of questions from members around both the DMHC all plan letter, as well as for those who have plans, and then writ large from the rest of my members around the CDPH all plan letters. And I've gotten interesting responses from the state agencies, I guess, and a lack of response from other state agencies. And so I guess maybe it's a question for Lisa around, given that you're the sponsor of the legislation and want to ensure that at least from the provider perspective, we want to follow the intent of where I think we all want to go. I think there's just some nervousness amongst different providers around, quote unquote, what is CDPH going to do, and quote unquote, what is DMHC going to do, and how are they going to respond to complaints, for example, because they will have an obligation to, at the very minimum, respond to complaints around that beginning in short order here. So didn't know if you had any conversations, Lisa, with either of the entities to get further guidance out there potentially to providers.
Yeah, I mean, happy to work with you, Trina, on, engaging the agencies for clearer guidance on any of these things, including enforcement. I will note, there is an intent requirement, right? Also just want to note that that July 1st deadline does not apply to providers. That is a vendor requirement for providers, that the obligation has already gone into place January 1st. But there is an enforcement delay. And we did the enforcement delay because we knew that we needed to trigger some of those protections and we needed to get the ball rolling on this. But we also understood that it was going to be difficult to move the sort of, this is kind of like moving the Titanic away from, its course. And so we knew that there was going to be some implementation issues that were going to come up. And honestly, this is the kind of implementation where we are going to have to work at various levels. There's not going to be one easy solution to fix this. And we'll probably have, be working both at the vendor level, the exchange level, the health information organization level. And, as what Dr. Lane presented is kind of the first step. But we understand that there's going to be some other issues, and happy to work with anybody to sort of understand what specific guidance we need from state agencies and work with those agencies to get that guidance that would make people feel better about things.
Thank you, Lisa.
We're here to
Appreciate it.
support that too.
Yeah, I appreciate that, Lisa, and I know we worked together on 352 and look forward to continuing that. And I think one of our challenges in terms of advocacy is you see one hospital, the vast majority are on the traditional EHRs, Epic and Cerner, et cetera, but we have a few that are homegrown. And so they are definitely in a different space and are in different levels. So appreciate the continued dialogue.
Yep, you know where to find me.
I know we had some facilitated discussion and workshopping, but this is such great conversation. I want to keep it going. Dan?
Thanks, Timmy. Great job all. Stephen, Ray, really good work. To be clear and to clarify, you reviewed the comprehensive data sets that are out there. Correct. We do not have an agreed to data set that must be filtered, redacted in compliance of AB 352. We're not suggesting, or you're not suggesting, either way, that everything you just reviewed with us has to be filtered and redacted to be in compliance with AB 352, are you?
Absolutely not, Dan. I think what the goal was to create a tool set that organizations could use to support their own compliance efforts, really looking at the clinical data, the definitions, the semantics of the data, and saying, if you are planning to redact abortion data, these are the subcategories of data that fit in that, and these are the individual data elements that fit within each of those subcategories. We are not lawyers. You can see a couple of doctors here.
But to the point, is there consensus with the panelists that we will need an agreed to data set in the state of California to be compliant?
I can try to answer that, Dan. I think that at this point, right now, there is not. And the state has not provided any guidance that they're going to enforce it in that way, that they're going to adopt some sort of standard code set, and that's the way they're going to do the compliance. I think in an ideal world, like, we would have some sort of understanding at the state level, maybe through the data exchange framework, about what that may or may not look like to ensure that compliance is easier for folks. But again, this is sort of just the first step that, Dr. Lane and has, helped put together as guidance. And just to be clear, there's also the Maryland also has a law that's very similar, but it's a little bit different. They actually have a state exchange. And so their law is targeted towards their state exchange. Obviously, we do not have a statewide exchange, so that solution was not really something that would have worked for us. We also strategically took slightly different approaches because we knew that implementation was going to be difficult. Just to see like what works better, honestly. And so, I think it's just sort of that first step, but there's no guidance from the state level that you have to adopt these code sets that, was just presented in order to be compliant or not compliant at this point.
Right. So I think it's so very broad. And if you're going to try to make something that's so very broad compliant, you're going to overachieve in many, many respects.
Yeah, it's hi, Ray here. This is tough because there is no formal clinical definition in the bill. What we would like from the informatics standpoint is that there are object identifiers with value sets specifically specifying which codes are defining the formal definition in the bill. You can see some of that in the Maryland bill, but there was none that I've seen in the California bill. Again, they were just stating different clinical elements there. We did our best effort to really segment that so that there's nobody's lumping together elective abortion with non-elective abortion, or just to help people kind of wrangle their data, because like we saw in the chat, there are some that are in structured forms and there's some that are in a free text note. This is really just a starting point, and nobody has an obligation to really use the value set. They can really make their own, but we just wanted to do the best effort to have a starting point for everyone to use.
Thanks, Ray.
Yes, you're very welcome. Thank you so much. A great question, by the way.
And while we're having this discussion, we also have a Jamboard available to everyone for you to jot down your ideas, other opportunities that we might want to explore. I mean, it really occurs to me that there seems to be a need to have a task force, or I don't know, Lisa, if you're thinking about pulling together some leading thinking on this, similar to what we're doing here, to be able to continue the discussion and really think about where and how there's some practicable solutions, and then be able to tackle areas that we know, can't be shored up very, very quickly. Seems like it'd be a natural next step, but I'm just going to throw that out there. Dan, did you have your hand up again?
I did. To your point, Timmy, which is a great, do we have a sense? Has anybody done an estimate of where the liability exposure load may be? Planned Parenthoods versus health systems versus individual practitioners, for instance. Has anybody done that work, has done that survey, done that estimate across the state of California? Does anybody know?
Sorry, Dan, can you just sort of elaborate on what you mean by liability in terms of like
Again, where is-
enforcement through the CMIA or enforcement through the state, or what are we talking about?
Lisa, the greatest number of records holding this data, is it primarily Planned Parenthoods versus health systems versus individual practitioners?
So
mean,
go ahead,
I
Dr.
was just going to say, it was interesting when we did our assessment, and when you come to the follow-up webinar on the 14th, we'll look at Maryland data, we'll look at national data, but it's interesting how rare this codified data is compared to how prevalent we believe these conditions and services are. So I think you ask a fascinating question, Dan, like where is the data if we're not seeing it in statewide samples?
Precisely, Steve, thanks.
And am I making the jump there that it's not being coded in the first place on purpose?
That's a reasonable hypothesis, right?
Yeah, and just so we're clear too, for us, it was intentional that we did not go down the code set route that Maryland did, because that was the approach that Maryland was taking. We also had trouble honestly defining specific procedures that would fall under this. Many patients do come, abortion is just one of the services that they're getting, and they have a lot of related services that would indicate that they did come to California for an abortion or that they had abortion services. And so it was very difficult to figure out what those things are. And again, one of the things that we are working on through implementation is to sort of gather some of those other data sets that's outside the code. I think, Dr. Lane, you mentioned sort of how do we gather some of that sort of unstructured data that actually could be very revealing on certain things. I mean, honestly, like our folks were looking at even just like pregnancy icons. So, we have EHRs. If you are pregnant, the patient gets a little icon that indicates that they are pregnant. And then, there will be an icon that indicates that they are no longer pregnant, or that icon remains in place even after they've had an abortion. And so those are some of the like weird little things that we have discovered throughout this process. And it's very hard to sort of, like legislate those things in a bill. That's generally not a good way to go about this. And so we are relying on implementation for more clarity. And I understand that that's a difficult place for folks, but that is, I think, a better place than having like really specific legislation on that. So it was a little bit intentional.
Ray here. Oh, sorry. I wanted to, if you would allow me to expand on what Lisa said. For example, pregnancy status is not a mandated structured data element. Even the representation of pregnancy status is not in USCDI version 3, Office of the National Coordinator for Health IT through the HTI-1 final rule mandate USCDI version 3. And we've been commenting for ONC to add pregnancy status, for example, and a multitude of other maternal health data elements that are now on what's called USCDI Plus. But for now, on the federal level, we're doing USCDI version 3. And a lot of the data elements there do not really encompass a lot of women's health or maternal health elements. So that has been a challenge. And it kind of to answer another person's question on the chat, what do you think about encounter level data as well? Even gestational age is not a standardized data element. Even last menstrual period, which estimates gestational age and putting the patients in which trimester, which has a lot of this political discussion on, is not mandated by law to be represented in the database in a structured way. So that adds to the even more complexity in protecting the data, or even trying to find that data in your encounter data or in a structured form. So we're trying our best here. So thank you, Lisa, for that. That's all.
And Stephen, thank you.
Timmy, I wanted to respond to your earlier question about, what does this say about how data is being coded? We did do a secondary analysis of the data in the Health Gorilla database, and we looked state by state, comparing the numbers of spontaneous abortions that had been codified versus the number of elective abortions. And it was fascinating. At one extreme, in the state of Washington, there are 10 times as many therapeutic abortions codified in the data than there are miscarriages. And in the state of Montana, there are 5 times as many miscarriages in the codified data than there are elective abortions, whereas the procedure is legal, in both states. In California, it was roughly equal. So there's just a tremendous diversity. Again, sampling errors acknowledged, but when you look at 27 million patients across the country, there's real diversity in how this data is captured.
Yeah, to add to what Stephen said, just one more final thing, if you would allow me. Even the code that semantically is equal to elective abortion, which is what's called Z code in ICD-10-CM, the use of those is very low because providers are afraid to code for that encounter information due to fear of retaliation as well. Not just for the Z code for elective abortion, we see this in social drivers of health as well. If the organizations don't have the capacity to treat that, for example, or protect that, providers are not incentivized to put that Z code in the problem list, which means the stuff that we have in the data might still be underestimating these numbers as well. So just one thing to think about when you're looking at your data as well, and as an example of how Health Gorilla is doing there. So.
And can I just follow up on that point? Is that I understand that there are these codes that differentiate between elective and non-elective abortions. That is not how our policy in California is set up. And clearly that is obviously a result of sort of national landscape around abortion exceptionalism, which is something that as a policy in California, we do not want to go. Like there's a diverse opinions on what is considered elective and what is not considered elective. And I do think that, for us as a policy standpoint in California, we try not to differentiate between different reasons why people may need an abortion procedure. At the end of the day, our policy is that it is healthcare and that it does not really matter why you would be getting an abortion. And so understanding acknowledging that there are these differentiations in the code sets, but also as California, as we try to lead the way in this, we do want to make sure that we are not stigmatizing certain kinds of abortion, other reasons why people may have an abortion procedure.
Agree, absolutely. Thank you for leading the way. Again, intent is not really the point, right?
Good reminder that words matter. Dan, you want to help wrap this up?
Yeah, Lisa, curious from your perspective, are the Planned Parenthoods in the state of California, I think there's 6 or 7, I don't recall, are they collaborating on how to best manage AB 352 compliance from a data, technology, sharing perspective? Is there collaboration going on there, Lisa, please?
Yeah, so there are in different ways. I will just, disclose that our affiliates we have 7 of them. They're all different, separate entities. They are not on like a shared EHR system or anything. And so we are collaborating with not just our affiliates here, but affiliates across the country, as well as some instances of Epic, to try to come up with a solution at that provider level as well in terms of compliance with 352. The thing about California is that we are a large market, and I will just say that there are other states that are also contemplating legislation that is very similar to 352. I think the large vendors have now recognized that this is happening, and are looking to work with us, not Planned Parenthood specifically, but providers in general who have identified this as an issue, to make sure that they can get into compliance with 352 so that when other states start passing similar laws, that they are ready to deploy something that's consistent across the country.
So again, California leading the way. So thank you all for contributing to the discussion. I'm hoping that there are lots of ideas collected on the Jamboard as well. We clearly have had a lot that we've heard here today that our team will pull together as a summary. And then we'll also work with you all. And I'm looking at Lisa, Dr. Lane, Dan, Dr. Yu, to think about what our next steps are. And we will certainly join the next webinar that Health Gorilla, is it Health Gorilla, Stephen, that's sponsoring?
We'll be putting it up, but Raymond and I think Lisa and others will also participate there.
Okay, so continue the discussion. So
Exactly.
real action for all of us to continue the discussion at that next webinar. And then if we have ideas on how Connecting for Better Health can continue to be a leader here too, we certainly, have the desire to do so. And I think that
just in response to that, I mean, as Dan said, and I think as you mentioned, there's been discussion within the community supporting the data exchange framework, CDII, about kind of how we're all going to approach this. I don't really think that's necessarily the right place to do it. I mean, there is a component of compliance which has to do with data exchange framework, but a lot of this goes well beyond that. I haven't seen anybody else stepping up to say we're prepared to convene the community of folks who need to figure out how to actually do this. I mean, there's sort of a blessing in the fact that there's no enforcement planned. So, I mean, even though that July date is looming, nobody's going to get their wrist too terribly slapped. But I think your organization may be in the best position to convene folks who are actually interested in not only understanding this, but actually sharing, implementation approaches,
Right.
et cetera. So I think something even, again, in our webinar, we'll dig deeper into some of that on the 14th, but I think it would be good to probably schedule a series of convening sessions for folks who want to actually come together as a community of practice and try to put this into effect.
we'll raise our hands to figure out how we can help. So thank you.
Thank you.
And I think with that too, if we could just speed through a quick update. So I introduced to everyone at the last meeting the technical assistance that Connecting for Better Health is offering. We've put that under the umbrella of the Data Exchange Framework Sandbox, but there are 3 offerings. One is a boot camp, which thank you, Maya, for dropping in that link, which is our first that we'll be offering of a series this year to help organizations understand what the DXF is. It's a half day to walk through with your team members and others, and really understanding where and how you are able to comply with the policies and procedures, identify your priority use cases, and then also have a roadmap when you leave the day with us. Then we also move into the Community Design Studio, which I'm so excited to say we have a beta partner with Partners in Care Foundation in LA County, who is working with us to develop their high priority use case, and we'll fully flesh that out over a 6-week period where we will work with them to develop the technical and functional requirements, as well as the synthetic data that we can then pull into our data exchange framework sandbox and test how a transaction moves from one point to another, and make sure that we are satisfying that use case. So super excited to be working with them. We thank them for their partnership, and we are opening for other organizations that want to also tackle high priority use cases with us. We're ready to go. So please, I think if you go to the next slide, we will, there we go. One more. We are open to working with you. So reach out to us. I'll put my email in the chat. You all know where to find us. But it's a methodology that's designed, that's user-centered, to be able to complete a use case that goes into the technical detail as well as the policy detail, which I think is so important to give that feedback to organizations. Finally, if you go back one slide, we are moving forward with improving our sandbox. So in addition to standing up our minimal viable product back in February, we also have some really great news to share around the visualization of the participant directory. And we'll go through a demo of that in our next meeting. But FYI, that's happening, and we're getting lots of great feedback from those that are on our co-design team. I think that's it. If we move to the next slide, our last slide, I think there's a update on everything that we're tracking. There we go, on upcoming events. So take a look at the PowerPoint. Always, it's so full of information. Our newsletter as well. We'll see you all on Friday at IHP's AI event. Super excited to see you all there, and we will be tabling about the data exchange framework. So come up, say hi, and let's create our community practice there as well too. All right. Well, thank you, everyone. We're a little over time. Thanks for such a great meeting. Again, more to come. Have a great day.
Thank you all.
Thanks, everyone.